Well, good morning. The countdown to Christmas continues. I hope you're prepared for what many kids would describe as the most exciting day of the year. And speaking of exciting, that's the way I would describe some of the advances in healthcare in recent years. And we'll talk about that starting right now.
From TV6, this is The Ryan Report. Here's your host, Don Ryan.
You know, as someone who's been around this life for a long time, I often marvel at the things we've discovered and the developments that have occurred. And healthcare is one area that's produced dramatic improvements during my lifetime. Clearly, we've learned much more about cancer. New procedures are extending the lives of those with heart disease, and we've even found new and improved methods for providing replacements for body parts that wear out. Replacing worn-out body parts is our subject this morning as we talk with orthopedic surgeon Dr. Keith Conley. Dr. Conley, welcome to the Ryan Report.
Thank you for having me.
Nice to have you with us. I understand you're actually an Escanaba native.
I am, yep.
You go to Escanaba High School?
I did.
So
yep.
you're an Eskimo through and through?
I was an Eskimo, yep.
Okay. And you're a family guy? You've got a few kids?
Yep. Married, have a 9, a 7, and a 4-year-old, so
Okay.
3 kids. Yep.
Do you have any time for any outside interests, or do your family keep you pretty busy?
Well, as you can imagine, with between the work and the family life, I stay pretty busy. But you know, I do enjoy getting out and skiing and playing guitar, and so I have a couple other hobbies that I try to keep busy with.
And I know you also, after high school and after college, I guess, served in the U.S. Navy. What was your role there?
So I was a submarine officer in the Navy, and I served on fast attack submarines for about 7 years after college.
Okay.
Yep.
And then where did you get your medical training?
So I went to University of Central Florida for medical school, and I was in the first class of that medical school there. And then I went to the University of Pennsylvania for orthopedic surgery residency. And then I did a fellowship at the Rothman Institute at Thomas Jefferson University, also in Philadelphia.
Okay. And so where did you actually start your medical practice?
So I'm starting medical practice up here. So
Oh,
this
okay.
was, yep.
So this is your first assignment. Okay, and
Yep.
you're fairly new in Marquette.
Yep, I am. We just moved up here this summer.
Okay. So you specialize in orthopedic surgery, but your specialty goes beyond that. Tell us about that.
So yeah, within most professions nowadays, it's commonplace to subspecialize, and with that, we develop better skills and more advanced training in a particular area, which in the end translates to better outcomes for the patient. So, my area of subspecialization is hip and knee replacements.
So how did you get there? How did you make that decision?
Well, I think a lot of where we go in life depends on the people we meet. And my father-in-law is an orthopedic surgeon.
Okay.
And he does hip and knee replacements. He was probably one of the first fellows in the country back when he trained. But he was a big influence for me, and so that helped guide me after the military to go into medicine and eventually into joint replacement.
A full disclosure for our audience, I have to mention that I first met you several weeks ago when you were doing hip surgery on my wife. And I have to tell you, we were both amazed by what that's all about, and we'll talk more about that. But who are the candidates for this type of surgery?
Well, really anyone that has advanced degenerative joint disease, meaning arthritis, that has failed conservative treatment. So anyone who's been through the non-operative options and really is just not able to get back to the level of function they want and the pain relief with that.
So what's happening within that joint that makes it go bad?
So there's a whole process that goes on, but in short, it's wear of that cartilage surface. So the cartilage is the smooth end of the bone that allows our joints to glide easily. And so when that starts to wear, that triggers this inflammation within the joint, and that inflammation is painful, and eventually we lose all of that cartilage surface, and we have what you call bone-on-bone arthritis. And so that process is what results in the pain and the dysfunction.
Are there other options besides surgery or earlier in the game, perhaps?
So definitely earlier we pretty much always start with the non-operative measures, which are anti-inflammatory medications is kind of the big one. There's injections that we can do. So for hips and knees, we can try a steroid injection. Really, the idea is just to calm the inflammation down. There's also some other types of injections that are available for knees as well, and then things like physical therapy, modifying your activities. Weight loss is another big one. So there's a number of things that people can try to do short of surgery to help account for their arthritis.
You know, in doing some reading, preparing for this interview, I read that we're seeing this happening at a younger age now. Some people in their 40s. You know, we kind of think of people being kind of ancient before they need this, but have you noticed that happening?
Well, yeah, I definitely have, and you know, I think a part of that is, you know, we have a very active population nowadays. You know, people are involved in numerous athletics when they're very young, and a certain portion of this is probably what we call post-traumatic arthritis. I mean, they've had some type of injury, and it leads to, you know, an earlier progression of this degenerative joint disease. And then the other thing is we're more aware of what's going on, and I think a lot of people are, you know, aware of what's happening with their body and what the treatment options are, and are coming in and getting treated.
I was surprised to learn, and I don't have the exact number, and perhaps you do, but when my wife was preparing for her surgery, she went to a class, I think, and they do more than 500, I think it was well over 500 every year at UB Health System Marquette.
Yep, that's about right. Yep.
That seems like a lot, but it must be what's needed.
Well, it's the number of joint replacements in the country has risen a lot over the last several decades, and a part of that is that we've gotten better at what we do, and you know, people are more aware of it, and the implants are lasting longer, so we're able to do it at a younger age in patients, and still expect them to last the rest of their lives. And then the population is expanding on the older end of the spectrum, just that patients are living longer, and so there's just more prevalence of arthritis and you know, joints that require joint replacement.
Okay, we'll have some more questions for you in just a couple of minutes. Back with more on today's show just 2 minutes from now. My guest this morning is Dr. Keith Connolly. He's an orthopedic surgeon in Marquette and here in the UP. Let's get down to basics. How does hip surgery actually occur? And I know you do the hip and the knee, and we'll talk about that too. But because I've had this kind of close relationship with someone who just had a hip surgery, what actually happens in there?
So the idea with joint replacement is to remove the worn cartilage surfaces and replace it with a prosthetic. Okay, so for a hip replacement, we essentially expose the top of the femur, and there's a number of ways to do that. I typically do it through the front, it's called the anterior approach. And with that, we make an incision, move the muscle bellies out of the way, and then expose the joint of the hip. We take that top part of the femur off and expose what's called the acetabulum, which is the cup edge of the socket of the pelvis. And then we find prostheses that will fit with that. So we essentially, based on the patient's anatomy, place a cup inside the pelvis, and inside of that metal cup there's a polyethylene liner, and that becomes the new joint surface on the cup side. And then on the femur side, there's a prosthesis that goes down into the femur, and then on top of that is a typically ceramic head, and so that becomes the new head, or the ball of the ball and socket joint of the hip.
So for a neophyte like me, I think of it as kind of as the top and the bottom.
Yep.
Are we doing much to the top?
So the top is all covered with cartilage, which gets worn out in arthritis. So in that side, we essentially take out that cartilage bone interface, and then there's a cup that goes, a metal cup that goes in on the pelvis side.
Do these new parts come with any kind of warranty, or?
So it used to be that patients were advised to kind of put off surgery until they were older, and really the limiting factor was the plastic or polyethylene liner that would go in on that cup side, and that would wear out over time. But with advances in the materials that we've been using, we just don't see that wear anymore. So from a wear of the product standpoint, there's really very little wear over time with current implants. Okay. There are definitely other reasons that they can fail, but in general, the survival for these is quite high now.
Well, and I have to tell our audience that both my wife and I were pretty amazed at how this goes. I mean, it's just really pretty amazing how quickly she recovered. And I understand the technique you use is a different technique than perhaps was used in the past. Not
Yeah,
suggesting you
so
invented
things,
it, but
you know, things definitely change over time, and you know, there's always kind of a sway to one technique or the other. But you know, the technique that I use goes through the front of the hip, like I mentioned, and so we don't have to take down certain muscles or tendons with that, and so it's a little bit, I think, less traumatic, and patients have a little bit easier time recovering quickly after surgery. And in the long run, there's been very good outcomes with really every approach to the hip. So
I know, you know, in some of the preparation and some of the studying she did, I mean, they talked about some real limitations on what you could do, but there really weren't any for her coming out of this surgery. I mean, you can't run a marathon.
yeah, so there's risks and benefits to everything that we do, and with some of the other approaches, the risk of dislocating, meaning that the ball coming out of the socket of the hip is higher, and so that's really what those limitations are for, and that risk is lower with the anterior approach.
So we should probably stress that every individual is different, and obviously surgeries always come with some kind of risk.
Yep.
So, but this seems to be working very well.
Yes, it's been, you know, the hip replacement's really one of the most successful procedures that's ever been invented. It's called the procedure of the century.
Oh, really?
Yeah, for the last century.
I was reading on the internet that some orthopedic surgeons are now trying a procedure to inject something to fill voids instead of doing this hip replacement. Are you?
So there's a number of different types of injections that are, you know, being trialed. There's not any good evidence right now that we don't have anything that will regrow cartilage essentially, or put cartilage back on the ends of the bone. I think that's quite a ways off, but you know, there's a number of things that, as I mentioned, as far as non-operative treatment options that we can try prior to surgery.
Yeah. And we've talked mostly about the hip, but is the knee surgery or the issues somewhat the same?
Pretty similar. With the knee surgery, it's a little bit of a different procedure. It's more of resurfacing the ends of the bone, so we don't take off as much bone, really taking off the bone cartilage interface at the ends of the bone, and then kind of capping it. So essentially replacing the cartilage areas with metal and plastic.
So we're making new advances in this area as well?
Yeah, so as I'd mentioned, for the wear of the hip, same type of thing for the knees, so those have been lasting significantly longer, and the reasons that patients require revisions 20 years ago really was because of that polyethylene or plastic wear, and today that's very low on the reasons for revision. So.
Okay. Some more questions for you in just a couple of minutes. Back with more on the Ryan Report after we take this break. Again, our guest this morning is Dr. Keith Connolly, an orthopedic surgeon in Marquette. You know, and before we leave the subject, you know, as I've said, we've been pretty amazed with the results, but I know it's important to emphasize that everybody is different, right? And there are risk factors and things to deal with.
Yeah, so certainly, you know, every procedure comes with risk, and we have to weigh the benefit of that with getting your function restored and relieving pain, and there are some things that we can try to do to make patients better candidates for surgery. So that's one thing that I you know, always talk to people about, is that things that tend to make you at a higher risk for a complication are things like your body mass index. So, you know, being significantly overweight is one thing that we try to work on to reduce that risk. And then other things like smoking, or if you have diabetes, trying to control it to the best possible level. Those are all important things preoperatively to focus on.
Let's talk about the group you're with. You're with Advanced Center for Orthopedics and Plastic Surgery. I believe, looking at your website, you have 24 different people involved in that organization.
So we have a number of different people working at the Advanced Center, and a number of surgeons. So really, we've kind of covered the areas of subspecialization, as I talked about, you know, earlier in the program, and so we really, you know, have somebody to care for just about every, you know, part of the body that you would need, that's been fellowship trained in that area. And then we have a number of nurse practitioners, physician assistants, physical therapists. So really a kind of a comprehensive orthopedic program.
I know looking at the website, it's down as finally as specialists for the hands and the shoulders and the feet, and
Yep.
it covers the whole body.
Yeah, and the idea is that being specialized in those areas, that focusing on those few procedures improves the outcomes. It makes us, much better at what we specifically focus on. And so, that's really the main goal, is to deliver the best care for the patient. That's where our specialty has gone to.
And you have, I guess your main facility is in the medical center in Marquette, but you also, your group does see people out around the UP as well.
Yep, we do. I see patients in Escanaba once a week, and multiple of us travel to other sites throughout the UP.
You have, you also have the Great Lakes Medicine and Life Performance Institute, a new building on Washington Street in Marquette. What goes on there?
So that's a very nice collaboration between multiple entities to really focus on treatment of sports medicine, rehabilitation, and we have a sports medicine clinic there as well. So, that's really that was a group effort between numerous rehab and Northern Michigan University, Upper Peninsula Health System, and us, and getting that together.
And I know in that sports medicine area, they work with a lot of athletes as well as they go through their process.
Yep, they really have just about everything you could need to comprehensively deliver sports medicine care.
So you're fairly new at this. I know your organization was probably started before you were born with two Dr. Elzingas. And they were orthopedic surgeons, but I have to imagine in their day they did orthopedic surgery, whatever was called upon.
Correct, yep.
I'm old enough to remember when kind of a doctor was a doctor, and you didn't have access to specialists, especially here in the UP. But we seem pretty well equipped now, don't we?
Yeah, well, the idea that the practice had, the way that they moved the practice to more than a decade ago now, was to try and bring that same level of care that you can get at a larger university medical center or another specialty hospital here, by bringing in the trained subspecialists here. And so that's really what they've accomplished.
And so it must also be nice, I imagine, to be able to do all of this done in a brand new hospital.
It is a very nice facility. It's nice to have that kind of state-of-the-art technology and the thought behind where the patients go, and I think it's much easier for everybody. Rather than most hospitals, or a lot of older hospitals have kind of been built upon multiple sections over the years. So.
Many of us got lost many times trying to find our way around Marquette General Hospital, for as good as it was. So I think, really for a rural area, we're doing pretty well here, aren't we?
So I think I think actually the health system in Marquette is kind of a model for what rural healthcare can be, by being able to get the care that you need in a kind of a centralized location like Marquette.
Okay. Well, you and your colleagues do amazing things. Thanks for coming in this morning and sharing with us.
Well, thank you very much for having me. It's my pleasure.
I'll have some other thoughts for you when we return just 2 minutes from now. I want to tell you today that I'm wearing a pair of shoes that I've had for so long, I don't even know how old they are. They're at least 30 years old, possibly 40. I don't wear them very often, but I did today so I could tell you this story. This is what one of the shoes looks like. I polished them up for the occasion. The point of my story is not that I'm so cheap that I wear really old shoes. The point of the story is that we just don't fix things anymore. But first, back to the shoes. Even though they're very old, they still look pretty good. They are the most expensive shoes I ever bought, a pair of wingtips from Allen Edmonds, a manufacturer of fairly expensive shoes. At least that was the case when I bought these. The reason they've lasted so long is because I took pretty good care of them, but I had the soles and heels replaced at least a couple of times. It was not uncommon to do that with a good pair of shoes back in the day. There still may be some people who take their shoes to the shoemaker for repairs, but I don't think it happens very often. For that matter, it's not something I do anymore. When shoes wear out, you toss them out. That's what we do today. Let me show you one more example from the past. My dad was a conductor on the LS&I Railroad. Never asked him why, but apparently it was essential that he have a good watch for his job. That watch was the Hamilton Railway Special, and you just saw it. This watch has to be over 60 years old. I don't use it, but I could, because it still runs today. You do have to wind it up every day or it stops running. When my dad was using this watch on the job, he would take it to the jeweler to get it cleaned and oiled once a year. If there was a problem with the watch, you would take it to the jeweler's and get it fixed. That's what we did in the past. Not anymore. Most of us, if we even wear a watch in this cell phone era, buy inexpensive watches and throw them away when they stop working. But it's not just shoes and watches. There are so many things we used to repair when they stopped working right. The toaster quit working, take it to the little shop where they fix those things. Radio busted, they could fix it. Toaster or radio stop working today, toss it out. Actually, you'd be hard-pressed to find that little shop that fixes toasters or small appliances. And if you could find such a shop, or if you took your cheap watch to the jeweler, it would cost more to fix it than it costs to buy it new. The fact is, we don't fix much anymore. That's why it was good to be reminded that one thing we do fix today is the human body. In fact, we do a better job at that than ever. Problem with a hip or knee, you can get a new one. And there's a lot more doctors can do to keep old bodies working. So it's worth celebrating that today we have ways to keep our bodies in repair. But as for the toasters, now they're out of luck. I'll be back in a minute. That's all the time we have for this morning. The Today Show is just a moment away. Remember, you can also watch this report at uppermichigansource.com. It's available as a live stream on Sunday, while current and past episodes can be found under the Ryan Report banner. Thanks to Dr. Keith Connolly for being here today to talk about joint replacement surgery, as well as other developments in orthopedic care. And thank you for joining us. Let's get together again next Sunday morning.